any of that? And you haven't even taken the test yet. Pretty good. Okay, now health promotion. Even though we might not know exact, we still know health promotion as it relates to hair, skin, and nails. And since you gave me melanoma, Kate, what would you say as far as a health promotion that you may know is appropriate or not as it comes to this, as it comes to melanoma?
Be protected when you're in the sun.
Where's sun protection, and what else about melanoma? For teenagers especially.
Tanning beds.
No tanning beds. Anything else? Health promotion.
Check your moles.
Check your moles. Good. Anything else?
Wear a hat.
Wear a what? Hat. It's for sun exposure.
Or body skin.
In interventions, you just learned something.
Nails.
What about nails?
Hygiene, do nails, keep them short, don't bite them.
Keep them short. Don't bite them. Don't wear nail polish. Don't wear false nails. Did you learn that?
Yeah.
Well, that's what I'm asking you. What you know? This is health promotion, right? So these are conversations you could have with your patients. Even maybe hair dyes, certain hair dyes, perms, especially if someone works in, a hair salon, they should be wearing a mask, especially if they're pregnant or immunocompromised or anything, or have lung problems, they should be wearing a mask. Does anybody know when we start screenings for body scans? What age?
40.
Nope.
Like mole scans?
A body scan, a typical body scan without someone having risk. At what age do we start that?
Like 30?
50. Now, if you have history of anything or in your family, you might start it early. So these are some of the screenings that you're going to start thinking about and committing to memory as you deal with patients. As we, as we move forward, it's going to make a big difference if you're working in a dermatology office or clinic versus, your level of knowledge is going to be superior to the average competent RN nurse and what they know about hair, skin, or nails. That makes sense, right? But that's going to be for every single one of these systems. You're definitely going to learn more depth if that is your primary population. The other thing we want to do with every single system moving forward is we will also want to think about how do we assess this system. For this specific system, it's inspection and palpation. We do not percuss for the system. We do not auscultate for this system. If you learn the order and which of the assessments you do, it'll really be helpful, particularly in the end analysis or in clinical when you're like, oh my God, how do I assess this? Okay, I inspect, I percuss, I palpate, whatever the order is, that will help you guide you what you should do next. So, we want to look at, what do we want to look at? What is this doing here? Oh, that's a question. Questions. So let's look at the STEM. The review system provides the nurse with what? What's the answer? Objective. This is the review of systems. That's in your complete health history. Right? Your review of systems is in the complete health history. Is that objective findings? No. Information regarding health promotion practices. Let's table that one. How about the next one? An opportunity to teach medical terms. Is that what we're doing during the interview? No. Necessary information so the nurse can diagnose the patient medical problem. Is that the point of our history? No, our point of our history is to collect data, establish a rapport, and do health promotion as appropriate. So what is our answer? B. Okay, let's do another one. So in the STEM, what are some of the key points that we're pulling out? He has pain in his foot. He's 45. It's a male. We know it moves up his calf, and it feels like fire, so that's giving us information if you're thinking about your PQRSTU. It further describes it as what? No prior injury, no falls. Which component of the pain assessment has the patient reported? So he told you what he thinks it is? No, C is the answer. Did he tell you when it started? No. Did he tell you the region, radiation, and quality? Yes. Fire, calf, all that. Did he talk about what makes it worse, what makes it better?
No.
So C is the answer. All right, anatomy is not something we're doing so much in this class. That was something you should have taken and come to us with. So if you need to do more anatomy, I would encourage you to look at the lab textbook in addition to having your textbook, the lab manual and your textbook kind of open, and remind yourself of some of the anatomy that perhaps didn't stay in your head. You are going to need anatomy to move forward and layer on top of that. But we have too much to do in this class to really teach you something you were supposed to have a prerequisite to come here. So, to be brief, you should know the different layers. Epidermis is the top layer, the dermis is the middle layer, and the subcutaneous layer is next. I'm going to go to this slide as I'm talking, and we know subcutaneous layer, and that yellow is all fat there. After that is the muscle, which is indicated on this picture. And this is also helpful when you're thinking about interventions coming up soon enough will be IM injections and subcutaneous injections. And you'll learn about injecting into subcutaneous. And oftentimes that is angled at 45-degree angle, unless of course the person has a lot of fat tissue, and it might have to go in straighter. You're going to learn this. Since the muscle is beyond all of this, if we are doing an intermuscular IM injection, that will be 90-degree angle in to try to get past all of this to get to the muscle layer. Again, that's interventions, not health assessment, but as far as this and moving forward, just know that the cuticle is at the base and the nail plate is another part of the nail that we will be exploring as we look at our assessment. You should know in anatomy and physiology should have taught you something about the function of the skin, and we know that the skin is the largest organ. It protects us. It prevents penetration as a barrier, so it really behooves us, not only as nurses to make sure we don't have any cuts on ourselves, but our patient and that assessment to ensure that their barrier is intact to ward off any type of infection. The skin also repairs, wound repairs and cell replacement. But the skin also is a sensory organ. So sensory, touch, pain, pressure, temperature are all things that our skin helps us to do. It regulates temperature for us. So sweating or diaphoresing is a term you are going to learn. Diaphoresing, D-I-A-P-H, is what happens sometimes, particularly post-surgical, that patients have profuse sweating. Or they may sweat, diaphorese, when they're having a heart attack. So it's something we would want to look at. We use it as a social indicator. It identifies us, what we look like. It's our characteristics, our coloring, our self-image is connected to our skin. We even communicate by blushing or blanching. Sometimes blushing could just be a hot flush, but it could also be someone, being shy. We are going to start with questions. That's our basic foundation, anatomy and physiology, and now we're going into the subjective data questions specific to health, skin health history. So this is like, they're called focus questions. While there are many, many, many different questions you could ask, let's focus on skin. These are some of the questions that you may ask. So previous history, good question for any system really. But if you're going to ask the question as it relates to skin, ask them, do you have any history with skin, hair, skin, or nails? And then maybe give them some examples. I'm going to name some. Any of these apply? Do you have any allergies? Have you had any hives, psoriasis, eczema, or anything else you could think of that might relate to your hair, skin, or nails that you can tell me about? Changes in moles. We're going to be specific about this because this is going to be an education that we need to provide to our patients as a form of health promotion. So changes in moles, any change in pigmentation to your skin, any excessive dryness or moisture on your skin. Pruritus, anyone know what that means? Itching, so any itching. Excessive bruising, rashes, lesions, medications. Are you taking any medications? Some that I would think about would be like for birth control, sometimes people get a mask of pregnancy, cloaca. Some medications make people flush. So there's different things that medications can. Some medications can give you hives. So there's different medications. If they're on, you might want to know about because they could relate to what's happening with the hair, skin, or nails. Again, alopecia is hair loss. Are there any changes in your nails? Are they brittle? Has the shape changed? Has the color changed? Environmental, occupational exposures. Are you exposed to chemicals or dyes or tanning, yard work maybe? Do you do a lot of yard work or outdoor type of work? Self-care behaviors, as we mentioned, false nails, tanning, these kinds of things. So you would go through a list of health assessment. You've done this already with health history, and I don't know, but for most of your groups, we said, like, try to limit to like 3 things. But again, if we're just dealing with this, it's going to be intense, and these are all the ones that are considered appropriate for hair, skin, and nails. After we've collected our subjective data, we're going to move on to our objective data. And I've already said the 2 methods we will use are inspection and palpation. Why don't we take a 5-minute break here and then come back? I keep looking at this clock. It's like 12:30. I'm thinking I'm holding you very long. Let's take a 5-minute break, come back, and we'll get into it. Inspect, and we're going to palpate. And really, you know what this class is going to be about besides really looking? It's about vocabulary and how to describe what it is you're seeing. So, when you do your assessment, your collect your objective data, it will be important to have good lighting, proper lighting, and anything with fluorescent light really makes you look yellow. So I don't think you want to really assess your kidney or liver patients that might have jaundice under fluorescent light. They might look a lot more yellow. So natural light would be best. You might need magnifying glasses. We have those things for you in lab. Gloves, maybe a ruler if you're trying to measure. Or we have little devices that have circles that you can measure how many centimeters something is. It's going to be very challenging when you have people of color. Darker skin is more difficult to see. Are they blushing? Are they looking yellow? So for those instances, you might want to look at the lips or the nail beds, under the tongue, palms of the hands, feet. But for sure, it is more challenging. Skin could look a little bit more ashen gray. Sometimes we see yellow fat deposits in the eyes, let's say, and that is considered normal for people of color. There are also going to be a lot of variables that could influence what skin looks like. And those variables can be the emotional state of the person, the temperature of the person, do they smoke cigarettes, have they been exercising, what position they're in. All of these kinds of things can change people's appearance and color. When we are looking at color, you want to look at the pigmentation, and basically normal is considered smooth and even toned. So are you going to write normal? No. Not at this stage in the game. You can't write normal until you're an RN and you prove you know what our normal is. You passed NCLEX. For now, you have to tell me what normal looks like when you look at skin. Because I've had you do this. You look at this page, look at one person on one side of you, turn your head to the left, look at the person on the right. Hopefully they're normal, don't say they're not. But they don't look exactly the same. So you have to say the skin is smooth or rough or even toned or not even toned and what it might be. But that would be the expression for pigment. And then when we get into the color changes, these are need to know. If this is not in your vocabulary yet, become familiar with it. Pallor is pale. Sometimes it could have to do with anemia, it could do with fear, anger, or someone that smokes cigarettes. Erythema is red. It has to do with increased blood supply onto the skin. It can happen when they blush, so embarrassment. It can happen for if you're overheated. Cyanosis is blue, has to do with decreased oxygen perfusion. Jaundice is yellow, and that usually has to do with excessive waste, not being excreted, therefore staying beneath the skin, which can change the color because it's circulating in the bloodstream. Temperature. So we will be palpating for temperature. And actually, we palpate with the dorsal side of our hands for temperature. Yes, dorsal side, the back of the hand. We have hypo, so decreased temperature. Usually we see this post-surgical, maybe environmental, it's cold out, maybe in distal limbs where the perfusion is not as good, or maybe if it's very cold, your feet could be colder than your core body. Or hyperthermia, which is high increased temperature. That could be for metabolism reasons. Maybe you just worked out. Maybe you have a fever. Maybe other metabolism besides exercise. Maybe local trauma or inflammation. You might have hyperthermia in a certain spot of the body. Moisture. We already mentioned diaphoresis as being something that we want to see profuse, that we don't want to see, but may see profuse perspiration for anxiety, pain, fever, different conditions. Normal for moisture would be smooth, even, so it shouldn't be sweaty here and not sweaty there, or dry in one spot and wet in another. So we're inspecting and palpating, and some of this might be done simultaneously, and I'm going to give you some just adjectives to use. So for texture, normal would be smooth and firm. Might it be as firm for a 20-year-old as it would be as an 80-year-old? So again, we're always thinking about our patient, the developmental age that they are. Now, the thyroid does affect the tissue. And we know with hyperthyroid, when you feel someone, it's a very velvety, smooth feeling. However, if they're hypothyroidism, they will probably have issues with dryness and rough, even flaky kind of skin. So thyroidism does affect skin. Thickness. We should again have an even, uniform thickness to the skin, except for two areas on the body that usually have more thick texture. Anybody have a guess?
Your soles.
Soles of your feet and your hands. But otherwise, this should be even tone. Even uniform thickness. Edema. We're going to learn a little bit more about edema in a bit, but that is fluid accumulation in the intercellular space. And the way we check this is with our, like a pincher. It will be on a scale from 1 to 4. So 0 is no edema. So 1, as far as edema, it would be 1, mild, moderate, deep pitting, very deep would be the last one. And we would usually check this on the extremities, although you can have edema on your nose in different places, but extremities, so going up the shin, you would depress going up the shin and see if there's an indentation. There'll be more on this. We'll come back to it. Mobility, just how the skin is able to move, or turgor is another word for it. Usually when you have edema, you have decrease in the skin being able to move because it's kind of puffed up with fluid. Turgor is something that we check to see about the elasticity of the skin, so can the skin move? Now, because hands are exposed to the elements, it's less indicative of someone's skin mobility because it could be drier. So you should reach underneath your clavicle and kind of pinch for a skin turgor and see if it tents. So this would be tenting. So someone that's dehydrated, if I pinch them here and a tent remained and slowly it went back, I could say they're a little dehydrated. However, in your book, it's showing you what tenting is, and they're using the hand. But I want you to realize that that's just showing you. So my hand, so I have a little bit of a tan from the summer, and you can see tent, and I'm also older, so you can see tenting kind of, it stays and then it goes back. Did you see that?
Mm-hmm.
So if I'm thinking about my whole body, whether I'm dehydrated, it wouldn't be accurate to test on my hands that have had exposure and are drier than less exposed areas. Does that make sense?
Yes.
So my point is, in your book, don't be distracted by, I think it's on page 226, the picture where they're showing you to pinch on the hands. That is not the appropriate place to assess for turgor. What that is demonstrating is what turgor looks like. But where should you do turgor? On the clavicle. Another thing we're looking at is vascularity and bruising on the skin. So vascularity may increase with age, and I'll let you look at my skin. I have all these little spider veins. They're lovely. You're really going to love getting older, let me just tell you. And then when we do peripheral vascular, you know, there's more likelihood you'll have varicose veins, but we're not going to really get into that right now. And when you think about vascularity or bruising, what color is it? Bruising can be many different colors: purple, blue, yellow, green. Vascularity can be red, it could be blue, usually. So think about the color. And then there's lesions. And again, we're going to get into primary and secondary lesions. Primary lesions are when you're first seeing it, so it's more diagnostic, and in some ways it's more advanced practice like APRN. However, secondary is about describing it, and that will be within your wheelhouse of what you will be expected to do. When you look at lesions, we want to look at the color. Does it elevate off the skin? Is there a pattern to it? Is there a shape? How big is it? What's the location? Is it all over the body? How is it distributed? Exudate. So is it oozing? Is anything coming out of it? And what's some things that come out of the body, like a cyst or pus? Yes. I think you have in interventions this week talking about documentation, and you know, as an attorney, I've seen my share of documents, medical records, and this is one of my pet peeves when people write, "It was pussy." So when you read pussy on a witness stand, there's no such word as pussy. Okay? So never write that in your chart. It either has pus, it's purulent, okay? You know, it has exudate, but I don't want to see anybody with pussy on their charts. Okay, you can tell Professor Kroll that story. Really, they destroyed one of my doctors with that one. Okay, so moving on. The skin is about educating, and there are little handouts going around, and this is going to be a need to know. A, B, C, D, E rule. You are going to look at the mole, whatever it is, and you're going to say, A, is it asymmetrical? So does it have round borders, or is it kind of like amoeba shaped? What are the borders like? Do they just kind of fade away? What's the color of it? What's the diameter? We want that diameter to be under 6 millimeters. So that's like the top of an eraser, you know, like a pencil eraser, that size. What's the evolution? Is it changing? Is it getting bigger? Is it getting elevating off the skin? Is any change happening? And while this is really significantly addressed in the media and elsewhere, we do have an aging population, and they have a lot of different spots. I mean, I feel like I'm polka dotted these days, and I wasn't that way when I was your age, but like, it's amazing how many spots you get as you get older. So there's another rule, and it is mentioned like in a little corner somewhere in your book, and it's called the ugly duckling rule. And this is another rule that we want to be thinking about. And basically what that says, especially for our baby boomer generation, is you've got a lot of spots on you. But do they all kind of look the same, or is there one that kind of looks different? And that's the one you should be looking at. Okay? So if you ever hear of that rule, it's really gaining more popularity now. I don't think it's given enough, in your book. I don't think it's really addressed enough, but it is in there. I think it's in a inside column, from what I remember. I don't remember what page it's on.
So if mole is more than 6 millimeters, you would recommend to have it diagnosed?
Okay, so here you go. We are just collecting data, first of all. We're not diagnosing. And one piece of data in and of itself does not make for a disease. So you're going to be in lab today, and let me tell you, I mean, all the diseases you're learning, you're all going to be convinced you're going to die of something. You have something that you either learned about already or haven't learned about. I mean, it's unbelievable. Like, all the guys are going to have uterine cancer, and all the girls are going to have prostate cancer. Something. You're going to think, oh my God, I have this. Look, I have all these things. You really can't isolate anything. It's always the big picture, which is hard to focus on when you're first learning. So if you go into lab today and you're like, oh my God, that's bigger than an eraser and it's 2 different colors. You better go. You better go now. Don't even finish the lab. Go immediately to the dermatologist. No. It's one piece of the puzzle. Okay? So this is just a guide. Excuse me. Even if they have all of these asymmetrical, it doesn't mean it's cancer. In fact, I'll show you one that fits almost all of these, and it's not cancer. So this is just a guide. It's a way to screen yourself. It's a way to ask for help. I can tell you I had a very superficial, I'll show you something that I have, and it wasn't even brown. Didn't look like anything, but it didn't look like any of the other ones. So the ugly duckling rule was helpful to me, whereas the ABCDE rule was not. Again, we're just collecting data. We're not diagnosing. We're not jumping to conclusions. What's that expression? A little knowledge is... What's that expression?
Nobody knows.
No? I'll try to look it up. Okay. So, hair. So we're looking at hair, and it's very easy for you to just say, oh, it looks normal. But if you look again, right to left, that looks normal, that looks normal. It doesn't look anything like the other one. So describe it. First of all, is it even present? And are we just looking at hair on the head? No, the whole body. And I have had patients, a male patient that decides to shave their chest because they're a bodybuilder, or just decides to shave their chest because, or wax, because whatever, they think it looks better. So you can't assume things. You know, people shave off their eyebrows, it doesn't mean they have chemo, I mean, I don't know. People do all kinds of strange things to the hair on their body. So we need to check all the hair on the body, not just the hair on the head. What is the color of it? Do they dye it? Do they shave? Do they wax? What's going on? Texture. So try to describe it. Thin, fine, straight, curly, coarse, brittle. There's a lot of different ways you can describe it. Distribution. Is it fine? Does it go from fine to coarse or coarse to fine? Maybe as you go down the leg. Does it go from coarse hair on the top of the leg, and this person maybe has, not such good perfusion, and by the time you get down to the toes, there's no hair? I don't know. That's what you have to look at. So distribution, what's the location? Do they pluck it? What's going on with it? Lesions, are there any sores? Are there any lice, dandruff, these kinds of things? For the nails, we're going to look at the fingers and the toes, and this is particularly important for diabetics or anyone with minimal perfusion to the external extremities. We're looking at the shape. So, is it smooth? Are they jagged? Are they dirty? Normal. So everybody take your fingers, put your nail beds together like this, and you should be able to see a diamond right there by the cuticle end, at the end of the nail bed. Okay, and that is, so if you look at it like this, now you can see there's a little divot, like a little dent in there, and that's normal. That's what we should have. That's 160 degrees. What we want to look at is, if you put your fingers like this, do we not see a diamond shape in there? Is it flat? That's 180 degrees, and that might be indicative of early clubbing. If someone has had trauma to these two fingers, are we going to do this? No, we'll use another finger perhaps to look at. If they've had trauma to all their fingers, it's going to be very difficult to do this assessment. So we're looking, and then the last would be if it actually, so what happens is this is normal, then it flattens, early clubbing, and then it becomes a real issue that the nail bed is clubbed. And that is a problem with perfusion to the extremities. Now, I worked with someone very healthy, eats well, exercises, everything, but she's had asthma since very, very young. When we were in about our early 50s, I'm working with her, and I look over and I'm like, oh my gosh, she's got clubbing. Like, it really looked like E.T., like, take me home. What's that expression? E.T. Looks volvulus on the end. I was like, oh my gosh, like who would have thought? And then I thought, oh my God, that's right, she has asthma, and it actually is affecting her now, 10 years later or so, with perfusion. So, consistency. We're looking at, again, smoothness and color. Do they have pallor? Do they have a cyanosis on the nail beds? What's going on? So this course, we are focusing on the normal, healthy adult. But obviously we're going to have a lot of, not in lab perhaps, but maybe some. And I want to just say this. Whatever happens in this class in lab stays in lab. I've already mentioned that. But we love freaks. Okay? If you want to share something freaky that you have, I'll share my freak, you could share your freak. It's so cool, because otherwise it's just like normal. It gets pretty boring. I've actually, and I'll indicate when I have pictures of some of my former students that shared their freak, and they had their freak on and they get into my PowerPoint, because it's just interesting. But of course, it's a private thing and you don't want to share some of your freak, that's fine too. So I'll just ask now, does anyone have, if you'd like to share, does anyone have Raynaud's syndrome? Okay, then is it pretty obvious?
Yeah.
Okay, so maybe not now, but maybe for colder weather,
Oh,
okay?
yeah. Even like
So
in
that'll
AC.
just be helpful if you don't mind sharing that with everyone. Well, you actually see that her nail beds may look paler or red. Which one do you get? Both or?
Red. My hand, well, my whole hand will turn both. Like it's like marbles.
Yeah.
My feet, everything.
So it's just a
arms.
cool variation that you will be able to see and go, oh, that's what it looks like. So thank you for sharing that. So I cannot and you will not be able to learn every single abnormal in the book. And I do, as I mentioned, feel that I'm your guide. So I'm trying to pull out some of the abnormals that I think are more common that you should be more inclined to learn about. So with that being said, it is important that you read the book and please look at the variations. But those things that I teach in lecture and put on the slide and point out and describe are more likely to be the ones I would ask you to know, since I'm guiding you and using my expertise to tell you these are more common. So when you're in the clinical setting, you won't be like, what's that? Like, you'll be more like, oh, okay. We talked about, might see this a little bit more. And true, eventually you're going to have to up your vocabulary. So when we're looking at some of these shapes, I would try to get you to think about describing. Always think about, how would I explain this to someone I'm on the phone with? I can't say, look. So I would have to explain it. And as we look at this, we can see that this first one here actually covers two. This is discrete. It means it's its own separate thing, so there's two of them. And also I would think, what shape does this look like? Circular. So that's how you would describe it if you were on the phone. They're discrete. There's two spots on the upper left shoulder blade. They're discrete, and then maybe measuring, tell them the size. Okay? Confluent is this one. What confluent means is that it's kind of coming together. They're not discrete, they're not separate, they flow together. Confluent. All right, and then over here we're looking at this. Do you see how these are grouped together? Not like this, but these. See how they're grouped together? So you'd say they were grouped. Now this could also be termed as group, but it's considered polysynclitic because there's more than one. They're round, circular, but it wouldn't be wrong to say these are grouped on the wrist, but that's not exactly, they don't look the same, right? So you could describe this more as polysynclitic, but not wrong to say group. So there's some interchange with what you're seeing, but just try to be descriptive. This one here definitely looks like what? Not a circle, but linear. So that's a linear one. This one looks very snake-like, so we call this gyrate. This is a very common one. It's called the iris or the target. Some call it a bullseye. Your book doesn't call it that. So we might think about that as connected to either ringworm or ticks, bullseye from a tick. And lastly, we have a zoster form. Now you might say that this is grouped. You could even say in some ways it's linear, but why this is distinctive, the zoster form, is that it's usually on like a nerve area. And again, it's just going to take time to utilize your vocabulary as describing these. Yes?
Can you, what is that circle one called again?
Target and iris.
This one?
Yeah.
That's the iris or target
Okay, thank
or bullseye.
Which one is the snaky one?
This one that looks like a snake.
Where is it? Isn't that there?
A
Oh,
gyrate.
there it is.
All right, so next, and this is what's going to freak you out, is this
Yes.
one.
No, this is different.
So, once again, primary skin lesions are more diagnostic, so less of what that you may, you will not be diagnosing patients, that's beyond your scope. If you are working in a dermatology place, you would probably, be very comfortable using all these different words. Some of them you already know, like pustulous or cyst, you kind of have a vision of what those are. But I'll just give you some basics, and what I tried to do from your book is to kind of group them into what you can feel or what you could just see, what has fluid in it, and what is palpable, so it's usually above or could be below the skin. And I'm hoping that makes it a little easier to categorize in your head. So a macule or a patch really is another word for a freckle. So the spot that we all have at least someplace on our body. And the distinction between the macule and the patch is really the size. So depends on the book. Your book says less than 1 centimeter for a macule. Some books say less, up to 2 centimeters, so less than 2 centimeters. So small, like what you would typically see as a freckle, versus a patch, which is maybe bigger than that. The vessels we see maybe with herpes lesions, cysts are fluid filled. You could feel those. They kind of even could feel rubbery. A bulla is larger. And we can see those more with burns. So imagine someone having, did you ever have a burn or like a blister kind of look?
Mm-hmm.
Anybody ever have a blister? It gets filled with fluid, so that's kind of a bulla. And pustule is what's filled with my favorite, pus. So acne situation gives you an idea of some of those. Now moles are a little different, and they're different from freckles because you could usually feel them. They're usually raised somewhat. Would you agree?
Yep.
So that's similar for the first two as well. A papule, also called a nevi, and that's usually smaller than a plaque, which is sometimes a little bit bigger, but both looking like moles or sometimes with a plaque though you could have dryness on the top of it. A nodule could be similar to a cyst, but again, more easily palpable, raised from the skin. All of you are familiar with a wheal if you've never heard of that, but that's like an insect bite. You know that look that you get on your skin when it's an insect bite? And then tumor and hives, you have an idea of what those things are? Yes? No?
Yes.
So the secondary skin lesions, if you look at the words, you'll see there's more, seems to be more descriptive, I would hope. I've included above the skin versus below the skin. So if something has scaliness to it, it's flaky, whereas crust is similar but thicker. Does anyone have a scar that kind of rose over your skin like when it healed? Okay, so if you want to show your group those, that would be atrophic scar. And this next one, I don't even know how to say it, lethification. Really what that means is it's just thickening of the skin. I won't kill you with that one. I've never heard anyone say that word in actual practice. It's probably just aggravated skin. I mean, it is aggravated skin, so that's how they'll say it. The skin looks aggravated or thicker. That's what they'll say. It's not like you throw that word out, they'll be like, oh, they know something I don't know. All right, so below the skin. And again, until you have context and have seen some different wounds, it's going to be hard for you to figure out where to use this terminology. But for excoriation, that is like if you've scratched something so badly that you've broken the skin, like an abrasion perhaps, a rope burn or a rug burn kind of, you know, that kind of on your skin, it's not smooth and it's scars, tissue replacement has changed, the collagen maybe is different than what your typical skin looks like. It might not be the same texture, it could be more smooth or less smooth, raised or not, or dug in perhaps. Keloids. Keloids can happen with Caucasian, but more typically people of color, and it's a healing that is deforming the skin. Usually it's deep below the skin, but it actually may rise above the skin as well. Oftentimes the color will be much darker. When I did, when I was interning and we had plastic surgery cases, most of these people had keloids that were just horrendous, like thick, ugly looking, scarring that, like if they had a facelift, it would be all around. It would look like a dark snake all over the skin, under the breast for breast surgery, like brutal. But really it had nothing to do with malpractice. It was how the person healed. But still horrible. I mean, you're going to try to do something to look better and you come out with this horrendous keloid. So they are very, changing body image. A fissure is cracked open skin, so that's definitely dug out. Erosion can be scooped out. You could have erosion after breaking a limb that's reset. You could have erosion after a trauma. And ulcers are typically depression. And we're going to talk about ulcers because this is a huge, big thing, and you're going to hear about this more in interventions. It is so important when you admit a patient to perform a thorough skin assessment. Now, as nurses, we used to do this during the bath, but we don't always do the bath now. Sometimes we delegate the bath. That doesn't mean that you should not, your own eyes, be looking at from every inch on that person. Because the first stage is so possibly insignificant, like you might not even see it. It's easy to miss that first stage. But if you, for insurance reasons, if you come in and you say your patient doesn't have any ulcers, and within 2 days, 3 days, they have an ulcer, insurance won't pay for that. That means your hospital will have to absorb the cost. If your hospital's paying for all those things, they're not going to be hiring nurses. So it really is a fiscal responsibility as well as a patient safety and improved outcome issue. It's huge. You'll be doing some of this in your Jerry clinical and, as I said, in interventions. But for right now, not everyone has that, but some of you cross your legs if you have skin to skin, or if you don't, just kind of press on your arm a little bit like this while I'm talking. So just press, either cross your leg. You know when you cross your legs and you get that little white or pink spot?
Yeah.
All right, we'll try to reproduce that on your arms as I'm talking. So the first stage can look like that. Skin is still intact, but the color is just a little bit off. So now look at your spot. Is it red or is it white?
White.
That's all it could be. That could be a first stage. But especially on bony prominences, so on the sacral area, on the heel, on the tip of the ear if they have oxygen. Any place there's pressure, a bony prominence, elbows against the bed, shoulder blade if they're really thin and their shoulder blades are rubbing against the sheets. All bony prominences you need to look at. Any place where you have friction, like I mentioned, equipment on the patient, blood pressure, whatever. Because it could be that subtle. So this is a lot more obvious. than really when it first begins. So be careful to look at it. It's intact skin, it's just a different tone. That's stage 1. Stage 2, this is looking a lot worse than some stage 2s, because some stage 2 you could still have intact skin, except there's a little blister forming. This is also a stage 2 because you could also have it where the skin, is removed. It's more than blistered, it's broken open. So that also could be a lot less severe and really be something. But once you start getting to stage 3, it's pretty obvious. The subcutaneous fat can be visible, and what color is that? Yellow. And stage 4 is brutal. I mean, you can see bone and tendons and muscle and the odor, and not to mention the pain that these patients must be in. Now, you will learn in interventions you have to stage, and each stage dictates how to care for the wound because each one is different. Is anyone here interested in being a wound care specialist? Yeah, me too. I'm like, oh, power to you, whoever wants to do that. But now they don't have 50 million in a hospital, they have less amount, but that is a job that people are going to need if you want to be a wound specialist. All right, some more abnormals. To group these, I want you to think about this is a change in the blood vessels underneath the skin. A hematoma is more an anomaly like birthmark, and 10% of people have birthmarks. This is one of the more common type, hemangiomas. I don't even know how to say this. We have to go to how do you say. Because what we usually just say is that these are like spider angiomas. That's what we usually call them. But go to how do you say to say that. That really has to do with dilation of the blood vessels under the skin. Oops. Now, the next one is a little bit more of a problem. It means that the blood vessels have burst under the skin, and typically these are telling you that there is some active bleeding going on. So what happens is that you blanch. Do you guys know what the term blanch means? Mm-hmm. So if you, we'll do it on the finger. So if you take your finger, look at your nail bed if you don't have nail polish, and it's pink, right? Mm-hmm. Maybe not for you. Find a pink one. Now squeeze it and release quickly. Do you see how it's a different color? What color is it? That's blanching. And you could do that to skin. You could blanch skin and see that, right? So if you blanch petechiae or purpura, it will not turn, it won't blanch, it won't turn white. Because there's active blood going on. There's active breaking of capillaries. And that's not a good thing. Whereas you can blanch the hemangiomas or the spider veins. And I have one that I'll show you in lab. I'm going to have everybody come into my lab. Can I see your spider veins? All right. So for lesions due to trauma or abuse, look at the pattern of the injury. Try to compare that to what is being told to you subjectively, if it makes sense. At your stage in the learning process, you're not going to know if it makes sense or not. But once you've done this over and over again, you know that that can't possibly be a fall out of a tree, because it wouldn't look like that. It wouldn't be rotated. That was happened from somebody pulling on the arm. You'll come to know these things. You don't know these things now. So you're looking at the pattern of the injury. Is it consistent with what was being told? Is there a hematoma? A hematoma is bleeding under the skin, like a vessel broke. Oftentimes that bleeding will rise up because of the bleeding under the skin pushes the skin up. However, you could have internal hematomas. Are you going to see that? No. Like you can have a hematoma in the vaginal area, you can have a hematoma rectal area, hematoma in the stomach. You really can't see that. But a hematoma on the head would be pretty obvious. You have the skull, and any blood would look like a lump. We're looking also at ecchymosis. That might be a new word for you. Ecchymosis is about bruising, and that would take us to the next slide. Recognizing that bruising comes in a lot of different colors. Now, it's important to document the color, and we know that the color goes a certain way. So initially, within the first 24 hours, it's going to look reddish, purplish. Then it's going to get darker. It's going to look a little bit more like a typical black and blue, so darker. Then it's going to start to turn bluish green. Then it's going to turn to green, then to yellow, and then it might even fade to a brownish color. And I think we've all had a black and blue or seen one, and you remember some of these colors. That is the progression. What we cannot do is say, oh, it's yellow, the injury happened 3 days ago. Because you may heal faster than you, so we don't know. We just know the staging order. We can't add that to a specific amount of time. But it still gives us information, so you should always be documenting the actual color and the location. Try to time it. Do they know what they think the bruise is related to? There are other reasons that you could have bruising. There are blood disorders. There's liver dysfunction. A person could be on blood thinners. There are many other diseases that can create issues, not only for bruising, but broken bones and different things. And probably they will have been suspected of abuse before they actually diagnose the situation. But that's not the normal. The normal is it's a trauma or abuse. So clearly we need to investigate, and as mandatory reporters, we do not need conclusive evidence, we just need suspicion to get social services involved and get people kind of looking. So here is another list of abnormals. This specific one is candidiasis, and it is a very common situation that you should know about. Another word for that is yeast. So your elderly patients will have it. Obese people will have it under their breasts, different parts where body fat kind of creases. You can have it in the mouth. You can have it in many different places. Sometimes it turns a little crusty yellow. It can be moist. The more moist it is, the longer it is to heal. Now, this can create diarrhea for the patient, not to mention itching and pain and discomfort. It's easily treated. So we need to recognize it and advocate for our patients to get it treated. The other one is impetigo. You should think about this also is very contagious, and there's some pictures in your book for that one. I have some pictures of some of the other ones I want to focus on. This first one is petechiae. This is a need to know because petechiae means bleeding under the skin, active. We see this with blood transfusions gone wrong. We see this with strangulation. We see this with allergy reaction to medications and different things. So that would be an important pickup for you, petechiae. We do see psoriasis even for young children, especially young children that are immunocompromised, anyone that had cancer, any diabetics. So there's a lot of psoriasis around, and it can be all different, very severe to just a few spots here or there. So very flaky, circular, discrete, but they can also be confluent. They can actually be like a huge patch on a larger part of the skin. And this last one, which one is this? New one, I'm going to ask you. Which is this bottom one? Because you asked it before. The bottom one? No? Bullseye. Target.
Oh, the crisis. What's that word?
Target. Iris.
Irish.
Iris. Okay, that's the bullseye one, and we should all be looking at ourselves. We live in Connecticut, so and that's why I put this one up here, because this is the home of Lyme disease. This is the season of Lyme disease. So spring, summer, fall, not winter, something common that you may have to deal with. You can have Lyme disease and this can go away. So this is the first step of Lyme disease that we see this, but then they can go away. Carcinoma is something more that you would be diagnosing. So the point is that it can come in all different shapes and sizes. And if you think about your ABCD, you see how this A is this symmetrical? Do you see the borders? Are they even?
No.
Do you see more than one color here?
Yes.
The diameter, you can't tell, it's larger than 6. And has it changed? That would be a question that we would ask. But look how big this carcinoma is. And I have had patients, I actually had a patient come to the clinic with a hole through her mouth, with a sore in her mouth. And I'm like, why did you wait? So like, who waits that long? Like, I don't even get it sometimes. And that could have been what the story was here. This guy could have just shown up for, like it's been going on for 10 years. Like, why today? On my shift, did you come in? You know. But, so they can look a lot different. All right, we are all out of time. There's just a few more slides that you could flip through with some abnormals, but I want you to know that the focus is what? What's the focus? Normals! Normals. You need to know your normals. You can't possibly know every abnormal. And when you start out in your career, what you're going to do is say, I don't know what it is, but it's not normal. Could you please come look at this? If I get a nickel for every time new nurses say that, I'd be rich. All right, so what time are we getting together?
1:30.
Yes, we are. We'll see you then. Be there, be square. What?
You still gonna stay in the library? Is it
You should be able to go